Hi. Today let's discuss about a 1-year-old child referred from southern parts of Tamil Nadu for evaluation of noisy breathing. And there are so many differential diagnoses offered by our postgraduates, and let's see what is that case actually. Right, and this is a 1-year-old boy referred from southern parts of Tamil Nadu for noisy breathing on and off since birth. That noisy breathing present during both day and night time, more so during periods of common cold. Inspection often revealed minimal suprasternal retractions. On inquiry, the mother says that the noisy breathing was present since birth. Otherwise, the child is normal with respect to anthropometry or feeding. Whereas the mother in law, who accompanied by the mother, says that yes, sir, it is there since birth, but more so in the past 2 weeks and little bit of fever along with the difficulty in swallowing. When we asked our postgraduates, there were four differential diagnoses offered. The first postgraduate told it must be due to an early onset adenoid and he wanted to take an X-ray lateral neck. But this is present during both day and night, as a result of which we can think that the pathology is in the larynx. And snoring or adenoid less likely to occur at 1 year of age. But we do see these cases of adenoid even at this younger age group, but unlikely. Second, can it be a simple laryngomalacia? So that what we can do, we can reassure the mother. But the mother-in-law was so reluctant and she said, we are from distant parts of Tamil Nadu, do something else, confirm your diagnosis. So shall I proceed for bronchoscopy to confirm the laryngomalacia? The third postgraduate told, sir, it is nothing but a simple common cold on and off, and it is nothing but a conducted sounds which occurs as a result of secretions occupying the anterior part of the nasal cavity. And the fourth postgraduate offered one diagnosis. What is that? Sir, it could be a case of laryngomalacia, but the child is having little bit of on and off low grade fever along with the difficulty in swallowing. Why can't it be a case of a retropharyngeal abscess? As because he votes in favor of mother-in-law. So what can we do? Unfortunately, one of our postgraduate took an X-ray which revealed this. So what is this? A spotter. So what is this actually? Look at this X-ray lateral neck. Actually, the first postgraduate took this X-ray to confirm his diagnosis of adenoid. But unfortunately, to our surprise, the X-ray is more in favor of which postgraduate? Yes, postgraduate 4. There is increase in retropharyngeal space. Look at this. Increase in retropharyngeal space. So when can we say an increase in retropharyngeal space? The answer is, so can it be a retropharyngeal abscess? Right. What next? Is it a case of shall I proceed for CT neck, MRI neck, nasal endoscopy, or go for antibiotics, go for incision and drainage if antibiotic doesn't work? So we don't know what to do. Before that, when will you say increase in retropharyngeal space is said to be present, or when the retropharyngeal space widening is said to be pathological? It is often said that at the level of C2, if it is more than 7 millimeter, so at the level of C2, it should be more than 7 millimeter, or at the level of C6, it should be more than 14 millimeter. But in this case, definitely is very much more than 7 millimeter at C2 level and more than 14 millimeter at C6 level. One more definition says that between C2 to C4, between C2 to C4, it should be more than one third of the width of the vertebral body. Definitely it is there in this case. Or at the level of C5 and C6, it should be more than half of the width of the vertebral body. Definitely it is there. So definitely there is an increase in retropharyngeal space. Definitely there is a pathological widening. So can it be a case of retropharyngeal abscess? Let's see. So look at this, an increase in retropharyngeal space. But on inquiry with the mother, it is so evident that there is no history of fever, significant documented fever, or odinophagia, and as per the mother history, the noisy breathing from second month onwards. So probably it is a case of laryngomalacia, but how can we document or how can we rely on this increase in this retropharyngeal space? But one of our fellow had advised for another X-ray lateral neck. Look at this X-ray lateral neck, an absolutely normal retropharyngeal space. Look at this X-ray, an absolutely normal retropharyngeal space at C2 and C6. So, what is the carry home message? The first X ray was taken in incomplete neck extension, whereas the next X ray, this one, the neck is not at all flexed, whereas the next X ray was taken with complete extension of neck. So, what does it mean? Whenever you take an X ray lateral neck to assess the size of the adenoid or the size of the retropharyngeal space, it should be taken in a neck extended posture to avoid what is that called as pseudo prevertebral thickening that occurs as a result of neck flexion. So this is called retropharyngeal pseudo thickening. So what is the carry home message from this video 22? Retropharyngeal pseudo thickening is a mimic of retropharyngeal soft tissue widening that occurs as a result of neck flexion at the time of exposure, X-ray exposure. So often when you plan to take an X-ray lateral neck or when you plan to look for a retropharyngeal widening, it should be taken in extended neck posture. Thank you. Thanks for your patient listening.